At the outset, I would like to thank Professor Roton for writing a wonderful book which is a must for all the neurosurgeons, and based on his chapter on the CP angle, I have made this lecture. CP angle is between the superior and inferior limbs of the angular cerebellopontine fissure formed by the petrosal cerebellar surface folding around the pons and the middle cerebellar peduncle. Cerebellopontine fissure opens medially and has a superior and inferior limb that meet at the lateral apex. You'll find the cranial nerves from cranial nerve 4 to cranial nerve 11 in the CP angle. Near the superior limb, you will have cranial nerve 4 and cranial nerve 5. Near the inferior limb, you will have cranial nerve 9th, 10th and 11th, and you will have the cranial nerve 6th at the base. There would be 3 neurovascular complexes which I will deal with in the next slide. So this is a very important slide. So the 3 complexes are the upper, the middle and the lower. Now the artery of the upper complex is superior cerebellar artery. It includes the midbrain. The cranial nerves included are cranial nerve 3, 4 and 5. The fissure associated with it is the cerebellomesencephalic fissure. The cerebellar peduncle associated with it is the superior cerebellar peduncle, and the surface of cerebellum which is associated with it is the tentorial surface of cerebellum. In the middle cerebral peduncle, similarly we have the ICA. The part of brainstem that is associated with it is the pons. The cranial nerves are the 6th, 7th and 8th. The cerebellar peduncle is the middle cerebellar peduncle. The fissure is the cerebellopontine fissure, and the surface of cerebellum is the petrosal surface of the cerebellum. In the lower complex, we have the pica, medulla, cranial nerves 9 to 12, the cerebellomedullary fissure, the inferior cerebellar peduncle, and the surface of cerebellum is the suboccipital surface. Coming to the upper neurovascular complex, it is commonly used to expose the posterior root of trigeminal nerve. Halfway between upper and lower border of pons runs obliquely towards the petrous apex, and it enters the Meckel's cave. Most commonly, the V1 fibers are rostromedial and the V3 or the mandibular division fibers are caudolateral, and it depends on the angle of long axis of cross section of nerve and the long axis of the body. There are multiple anastomoses which are present between fibers from all the division, and that can be one of the reasons for the failure of operation of trigeminal neuralgia. Coming to the various orientation as I had talked about, this is the type in which V1, V2, V3 are located like this, and they can also be located at 45-degree angle and 10 degrees angle. There can be presence of aberrant rootlets, and they frequently enter the first division. The motor rootlets are rostral to the main sensory core, and the number of motor rootlets that are seen are 4 to 14. The aberrant rootlets can be up to 8. Anastomoses can be also be present between the sensory and motor roots. So all these aberrant roots, the various anastomoses, can be the reason for the failure of surgery for trigeminal neuralgia. As I said before, they may result in accidental preservation of sensation after posterior rhizotomy or section of the posterior root. So this is a figure showing the motor rootlets and the aberrant rootlets. The motor rootlets are rostral to the main sensory core, and the aberrant rootlets can also be seen up till 8. Now, anatomy of the vascular compression in upper neurovascular complex. In 1934, Dandy postulated that arterial compression and distortion of the trigeminal nerve might be the cause of trigeminal neuralgia. The craniotomy which we do for the trigeminal neuralgia is based on the upper half of the sigmoid sinus. So only a narrow brain spatula with 3 mm tip, which is parallel and just below the superior petrosal sinus, is used. We elevate the superior lateral margin of cerebellum. If there is any bridging vein, small one, which can be divided, we do that. As we can see, the placement of the spatulas in the various surgeries for the CP angle. For the upper surgery, we use a narrow spatula. Common finding or the most common culprit in trigeminal neuralgia is the loop of superior cerebellar artery at the junction of main trunk with the origin of rostral and caudal trunks. and the most common point of contact is the superior or the superior middle aspect of the nerve. It is very important to always explore the medial axilla of the nerve, because otherwise a vascular pathology or the vascular compression may be missed. This is the demonstration of the positioning. Normally we do it in lateral position in our institute. It can also be done in supine position with a head turn. As we can see that the burr hole is made at the transverse sigmoid junction and a small craniotomy is done. The cerebellum is elevated superior medially using a narrow spatula, and it can be seen here in this pictorial representation that this is the trigeminal nerve, and there is significant vascular compression at the axilla of the nerve. So it is very essential to explore the axilla, and we can see that the SCA is dividing into a rostral trunk and a caudal trunk, and this is the point of maximum compression in most of the cases. This is another pictorial representation of the cadaveric dissection of the trigeminal neuralgia, and all these photographs are taken from the Roton textbook, and these are the various sources which can cause the trigeminal neuralgia, the various arterial vascular pathologies, such as there can be from the caudal trunk, it can be from the main trunk, it can be from the rostral and the caudal trunk both, it can also be from an ectatic basilar artery, it can be from an Ica loop, it can even be from a large pontine artery, but the most common is the main trunk at the junction of rostral and the caudal trunk. Now this is the pictorial representation of the same picture from an intraoperative view, and you can go through these images. Now venous compression, it is less common than the arterial compression, and the most common source is the transverse pontine vein. Other veins can be the vein of middle cerebellar peduncle, vein of cerebellopontine fissure, and the pontotrigeminal vein. So these are the various venous sources that can cause trigeminal neuralgia. The most common, as I said, is the transverse pontine vein, and there can be various other pathologies such as the vein of cerebellopontine fissure, vein of middle cerebellar peduncle, etc. Now coming to the Risa approach, which was more popularized by Sammy, is the Risa approach. The suprameatal tubercle is the prominence at the superior lip of porus of internal acoustic meatus. It blocks the access to the lateral margin of trigeminal nerve and prepontine cistern medial to the trigeminal nerve. Its boundaries are inferiorly, it's the internal auditory meatus, superiorly is the petrous ridge, laterally is the vertical line crossing the posterior edge of porus of the internal acoustic meatus, and medially is the vertical line crossing the medial edge of the trigeminal notch. It's very important to note that the removal increases the access to the upper neurovascular complex around the trigeminal nerve by 8 mm to 13 mm. So in many of the institutes, a Risa approach can be used for tumors such as trigeminal schwannomas, which are dumbbell shaped and have significant portion in both the middle fossa and the posterior fossa, and there have been many studies which are comparing the Risa versus the anterior petrosectomy approaches, and they have found that even the Risa approach is good enough, and some have even found that it is better than the anterior petrosectomy approach. So this is the example of the Risa approach, in which you can see that there is the suprameatal tubercle which can be drilled, and look at the exposure after drilling. A lot of exposure around the upper neurovascular complex has increased. So this is taken from Sammy's retrosigmoid intradural suprameatal approach to Meckel's cave and the middle fossa, the surgical outcomes and technique, and he has also showed that there is a very good outcome. If we take out the suprameatal tubercle, we get a lot of space in the upper neurovascular bundle. Now this is the case that he had mentioned in the same paper, describing the Reza technique. As we can see that there is a dumbbell shaped tumor which has component both in the middle fossa and the posterior fossa. That's the posterior fossa component, this is the middle fossa component, and we can see that post-op there is no residual tumor and there has been complete resection, and we can see that the suprameatal tubercle has also been drilled. These are the intraoperative pictures that Dr. Sami had mentioned in the paper. He had mentioned the suprameatal tubercle, which we can see here, and we can see the trigeminal nerve and the upper neurovascular bundle. As we can see, he is drilling the suprameatal tubercle, and after drilling of the suprameatal tubercle, the exposure around the fifth nerve or the upper neurovascular bundle has drastically increased, and he could achieve a gross total resection in this case from a posterior only approach, and he didn't have to use the Kawasai's approach or the anterior petrosectomy approach. So coming to the middle neurovascular complex, it includes the ICA, pons, middle cerebellar peduncle, cerebellopontine fissure, petrosal surface of cerebellum, adhesions nerve, facial nerve, and the vestibulocochlear nerves. Anatomy of the vestibular schwannoma: laterally it expands the meatus. It may seldom erode into the vestibule and the cochlea. Medially, it compresses the brainstem and cerebellum and the fourth ventricle. The various classification system of vestibular schwannoma based on the compression, such as the Hanover classification, the Coase classification based on the size. You can go through all those classifications as well. It is very important to identify the nerve proximal and distal to the tumor before tumor removal. Now coming to the meatal relationships, they are very important. The position of the nerves is most constant in the lateral portion of the meatus. You have to remember the two structures, the transverse or the falciform crest, which is horizontal, and the Bill's bar, which is vertical. Now this is a beautiful demonstration of the internal acoustic meatus. We can see the ISC dura in the first picture, and after removal of the dura we can see the transverse crest. We can see the superior vestibular nerve, the cochlear nerve, the inferior vestibular nerve, the facial nerve as well, and we can see the loop of ICA which gives rise to the labyrinthine artery. So a simple diagram would be seventh nerve, the cochlear nerve, superior vestibular and inferior vestibular. This is superior, this is inferior, this is anterior, and this is posterior. And you will find the nervus intermedius or the nerve of Risberg, which carries the sensory and the autonomic part of the facial nerve along with the facial nerve. That's further dissecting into the internal acoustic meatus, beautifully shown in these diagrams. Also, we have to be wary of the jugular bulb. On the CT scan, we have to look for the high riding jugular bulb. Normally, the jugular bulb is more than 5 mm from the internal acoustic meatus. If it is less than 5 mm, it is known as a high riding jugular bulb. And during drilling, we have to be very careful because we may drill into the jugular bulb. We also have to be wary of the endolymphatic duct and the endolymphatic sac laterally. Now this is another pictorial diagram which shows the displacement of the facial nerve by the vestibular schwannoma. Now coming to the brainstem relation of the facial nerve, it is again very important to identify the nerve, and in the brainstem one of the most important structure we have to see is the pontomedullary junction, and it is 1 to 2 mm anterior to the 8th nerve. We also have to look at the lower cranial nerve. It is a very important landmark and more easily seen than the pontomedullary sulcus. So the facial nerve is 2 to 3 mm superior to the most rostral rootlet of the glossopharyngeal nerve. The other important landmark is the choroid plexus and the foramen of Lucia. It sits on the posterior surface of cranial nerve 10th and cranial nerve 9th. Another important landmark is the flocculus. So it's a very beautiful diagram showing the relationships of the facial nerve at the brainstem level. So we can see that this is the facial nerve. Now this is the most rostral rootlet of the glossopharyngeal nerve, and the facial nerve is around 2 to 3 millimeters rostral to the rostralmost rootlet of the glossopharyngeal nerve. We can also see the foramen of Lucia and the choroid plexus, and the facial nerve is anterior to the foramen of Lucia and the choroid plexus. We can also see its relation with the pontomedullary sulcus. That's another view, an anterior superior view, again demonstrating the same relationships beautifully. Now this is after the relationship of the foramen of Lucia to the cranial nerve 7th. I have already explained this, and in this diagram, after removing the cerebellar tonsils and after opening the tila, we can see it more beautifully. Now coming to brainstem relationships, which are arterial, the ICA rises from the basilar, mostly passes below the cranial nerve 7th and 8th during their course in brainstem, but may lie superior to or in between the nerves, but it mostly passes below the cranial nerve 7th and 8th. It has a rostral branch and a caudal trunk. The larger one is the rostral trunk, which is above the flocculus, and the caudal one is below the flocculus. Pica, it arises from the vertebral and it passes between the cranial nerve 12th and cranial nerve 11th, and then between the cranial nerve 11th and cranial nerve 10th. And SCA is above the trigeminal nerve. As we can see from this picture, this is the pica, as I have showed its relationship first with the hypoglossal nerve and the spinal accessory nerve, and then with the vagus and the spinal accessory nerves. We can see ICA, which is usually below the 7th and 8th nerve. It has a rostral trunk which is larger, which is above the flocculus, and caudal trunk which is smaller and below the flocculus. And SCA we can see is above the trigeminal nerve. These are the various other views demonstrating the arteries, and we can see the various sorts of displacements of ICA by the vestibular schwannoma. Now coming to the venous relationship. So the veins that we have to remember are the vein of the cerebellomedullary fissure, the veins of the pontomedullary fissure, the retroolivary vein, the vein of the middle cerebellar peduncle, which is formed by the vein of the pontomedullary sulcus and the retroolivary vein. Then there is the vein of the cerebellopontine fissure, which is above the flocculus. We have the transverse pontine veins, and we have the superior petrosal veins. So as you can see that from this diagram, we can see the various veins, such as the veins of the cerebellomedullary fissure, the vein of the middle cerebellar peduncle, the medial anterior pontine mesencephalic vein, the vein of cerebellopontine fissure, the transverse pontine vein, finally the superior petrosal veins. So it is also important to remember these veins. Another diagram showing the various veins at the level of the CP angle. Now coming to the retrosigmoid approach, the intradural exposure is between the plane of the posterior face of the temporal bone and the petrosal surface of the cerebellum. It is important to know that tumor surface should be allowed to settle away from the neural tissue rather than neural structures being retracted away from the tumor. There should be no attempt to see the whole tumor upon initial exposure. It is always important to remember the landmarks, because anatomy in CP angle is most important. So always remember the meatal relationships, the brainstem relationships of the facial nerve. As the intracapsular contents are evacuated, the tumor shifts laterally, and residual tumor is most commonly responsible for apparent adherence to neural tissue and not the adhesions. It may be often essential to sacrifice the subarcuate artery. It doesn't have much significance. It is important to preserve the posterior semicircular canal and its common crus with the superior canal, which is lateral to the posterior meatal tip. So while doing a CT scan, we always have to see, along with the high riding jugular bulb, the posterior meatal tip and the extension of the posterior semicircular canals. It is important to preserve the vestibular aqueduct and the endolymphatic sac, as I showed in the previous diagrams. And as I said, the high projection of jugular bulb blocks access to the posterior meatal lip. The facial nerve is identified near the origin of facial canal in the anterior superior quadrant of meatus. Dissection along the vestibulocochlear nerve, medial to lateral, is very important. The direction of dissection should be from medial to lateral, because traction medially leads to tear in the filaments of the cochlear nerve. Any artery that strands the tumor capsule should be treated as a end-passage vessel or normal neural artery and should be preserved. Always minimize the venous sacrifice, and minimal possible vein should be sacrificed. The mastoid ear cells, which are usually opened while we do the exposure and during the opening of the posterior lip, needs to be waxed, and if required, sealed with fat and glue. So this is the pictorial representation showing the vestibular schwannoma and its arterial venous relationships. This D diagram, the first diagram is showing the neural relationship. This diagram is showing the arterial normal relationship. This is showing the venous relationships, and we can see the displacement of the artery, veins and the nerves by the tumor vestibular schwannoma. It's another diagram showing the landmarks. Now coming to the anatomy of vascular compression in the middle neurovascular complex. So Gardner was the first to treat hemifacial spasm by removing arterial loop from 7th nerve. Janetta found the mechanical compression and distortion of the root entry zone of facial nerve in all of the 47 patients with hemifacial spasm. It is proximal to the Augustino-Redlich zone, the glial neurolaminal junction, and the most common cause is ICA and the pica. And the most common vein is the vein of the pontomedullary junction. The most common type of hemifacial spasms begins in the orbicularis oculi muscle and gradually spreads downwards. Anterior-inferior aspect of the nerve root exit zone is compressed. Atypical hemifacial spasm may also be present, which begins in the lower or the mid face and spreads upwards, in which the posterior superior aspect of the nerve root exit zone is compressed. There can be cross compression of the facial nerve by the arteries coursing at right angles to the nerve at the root entry zone, which is the essential element. And craniotomy for hemifacial spasm is positioned behind the lower half of the sigmoid sinus. So inferior lateral margin of the cerebellum is elevated. A arachnoid between the 9th and the 10th nerve is open. The choroid plexus is elevated from the posterior margin of 9th nerve. Always remember the landmarks. Elevate the lower margin of flocculus and always explore the interval between the 7th nerve and the 8th nerve. So as you can see, this is the anatomy of the arterial compression of the middle cerebellar complex. We can see that from the basilar artery, we have the ICA loop, which is compressing onto the facial nerve. This is another diagram showing the same. Coming to geniculate neuralgia, the nervus intermedius has 3 segments. Medial, it adheres closely to the vestibulocochlear nerve. The intermediate segment, it lies freely between the acoustic nerve and the motor root of the facial nerve, and it is the one which is divided in geniculate neuralgia. And the distal segment, which joins the motor root to form the facial nerve. Most commonly it is a single trunk, and sometimes there can be as many as 4 rootlets, and it arises anterior to the superior vestibular nerve. We can see the example of geniculate neuralgia. This is the diagram of the nerve of Risberg, and we can see the variations. It can be a single trunk and it can be series of rootlets as well. So coming to the lower neurovascular complex, we have the pica, medulla, inferior cerebellar peduncle, cerebellomedullary fissure, suboccipital surface of cerebellum, glossopharyngeal nerve, vagus, spinal accessory nerve, hypoglossal nerve. The glossopharyngeal nerve, 1 or rarely 2 rootlets are present, but most commonly only a single rootlet is present. It has a larger dorsal, which is the sensory, and a small ventral motor portion. It lies in the post-olivary sulcus at the level of superior 1/3 of the olive. The vagus nerve is multiple rootlets which are caudal to the 9th nerve in the post-olivary sulcus at the level of superior 2/3 of the olive. The spinal accessory is again in the post-olivary sulcus at the level of lower 2/3 of the olive and upper cervical cord. And cranial rootlets, more properly regarded as inferior vagal rootlets only, since they arise from the vagal nucleus. And hypoglossal nerve is the line of rootlets along the anterior margins of lower 2/3 of the olive, and they are in the pre-olivary sulcus. 9th, 10th, 11th is in the post-olivary sulcus, and 12th nerve, the hypoglossal nerve, is found in the region of pre-olivary sulcus. Thank you.